Hi, my name is Kat Geiger. I'm a DCSW, LCSW, and I'm the founder and CEO of Thrive Wellness Reno and Thrive's Greenhouse. I am here today to interview the world famous psychologist, Dr. Eric Storch. Eric is the professor and McIngvale Presidential Endowed Chair at the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He serves as vice chair and head of psychology and oversees the CBT for OCD program at BCM. He also serves on the board of clinical advisors for Thrive Wellness Reno and Thrive's Greenhouse, the residential treatment program for kids and adults with feeding, eating, and OCD/severe anxiety disorders. Dr. Storch specializes in the nature and treatment of childhood and adult obsessive compulsive disorder, anxiety disorders, PTSD, and anxiety among youth with autism. He's received multiple grants to investigate treatment efficacy, mechanisms of action, and how to enhance outcomes for those struggling with these conditions. All right, thank you so much, Dr. Storch, for being here today and letting me interview you and ask you all these questions and pick your big, beautiful brain.
You're the first person who's ever said that, but it's completely my pleasure. And it's an honor to have this collaboration.
Cool. Well, I want to just share with you and with whoever's watching today about what it means to be on our clinical advisory board. So we really believe in emulating our heroes in the field. We believe in learning from them, being mentored by them, and looking like them in every way that we possibly can as far as treatment goes. And so part of the reason we invited you and wanted you to be on our clinical advisory board is because you have done so much incredible work in the field of OCD and really, really solidified a lot of wonderful processes and efficacy and everything in the field. So we're grateful for you, and we're excited to have you advising us and mentoring us.
It's completely my pleasure. One of the things that's so exciting is seeing how the field has evolved in a way where there are more groups that are doing robust evidence-based interventions, and that's what Thrive's all about. Mm-hmm. So being able to contribute in some way to the organization, to the success in order to help kids is really, really meaningful.
Thank you. Well, you ready? You ready for all the questions?
Oh, yeah, let's do it.
Okay, here we go. So for a therapist that wants to start specializing in anxiety treatment, what would you say is the best first step?
One of the things I think that has really been a disservice in our field is that we've trained providers to be generalists. Now, no other discipline of medicine or helping professions really is that the case. People have a specialty. You have a cardiologist, and even within cardiology, for example, you'll have subspecialties. And I think that's the first thing that we need to appreciate as a field of psychotherapists is that you want to pick something that you really connect with, that you understand. And then from there, it's dive in with specialty training, dive in with expert supervision and mentorship, and then don't ever stop learning. Within that, one of the things I've loved about the OCD and anxiety community is how welcoming the professional community is, as well as the people that are struggling with those conditions. And so my other piece of advice is get involved, whether it's at a city or local or state level or a national level. There's so many things that you can do to start spreading advocacy, trying to share information about effective interventions, as well as developing, of course, different clinical supports to serve those that are struggling.
Love that. Great answer. All right. What do you consider your most seminal study that you've been a part of, and who did you publish it with?
I don't think I'm old enough to have anything seminal at this point.
Hard disagree.
There are a couple that I love, and one of them was one that a project I did with Dan Geller out of Boston, where we had a theory that this medicine called D-cycloserine was really safe and targets a core element of exposure therapy, might make exposure therapy work better in kids with OCD and faster. And so we had a pilot study that actually suggested this. And then we got a big grant from NIH. And the minute that we pushed the button to analyze it, absolutely no effects whatsoever. Now here's why I love that study. What we showed, however, was that if we gave kids with OCD 10 family-based exposure therapy sessions, most of them got better. We also showed that attrition to that treatment was almost zero, and that families really benefited from it, but found it very acceptable. And so even though our hypothesis wasn't proven, there were all these other lessons learned that were really critical, namely family-based treatment, have values-based exposure that's intense and aggressive, and have a laugh as you go along with it. Be a normal person. Now, the other study that we're actually starting our 5th year today, in fact, is one called the Latin American Trans-Ancestry Initiative in OCD Genomics. Now, I'm not a geneticist. I'm a guy who likes to work with people with OCD and understands the condition. But what's been amazing about this initiative, which covers over 10 Latin American countries, as well as the U.S., and seeks to examine the nature of OCD in a more diverse sample of individuals and address the lack of diversity that's been sort of plaguing psychiatric genetics, is that we've developed all these ancillary types of things going on to the project. For example, we do yearly trainings on exposure therapy in a country. Or we're having our 4th annual Congress on OCD in Latin America in Valparaiso, Chile, this coming September 2025, where we're really able to disseminate information to practitioners across the world. And so while we may have genetic discoveries from this study, for sure we will develop a new workforce of clinicians, address stigma, and engage future researchers in Latin America and doing research in OCD.
Amazing.
Yeah,
There's
really
so many things that you said in that answer that I could just riff with you about for hours that are really, really cool. I want to just name a couple of them. So the first is, as a Berkeley social worker, I, to my core, believe that representation in the field, seeing a psychotherapist that looks like you, is one of the most important things you can do for kids struggling with any sort of mental health disorder, because it means that there's hope. They can do whatever they want to do at the end of the day for their career. And so I love that you're training so many people in diverse countries that are not just plain white bread therapists from the USA. I also wanted to just comment on family intensive treatment. We're really focusing at Thrive on family intensive recovery. And so that means from day one, we have parents involved with the ERP sessions and learning. And I think that was something that you really emphasized at BTTI last time I was there, is just how critically important it was from the very beginning to involve parents and how much that changes attrition. So thank you.
Yeah, of course.
All right, more. So if you weren't a world famous psychologist, what would you be? Besides maybe a Phil Collins roadie, American Idol,
He's all right.
Yeah, karaoke bar owner.
This is true. So there are a few possibilities that come up. So right now, I'm currently trying out for the Houston Dynamo soccer team. They don't know it, but I think when I played in my over 50 game recently, in my mind, that was the whole purpose. So
Second career.
Yeah, second career. Unfortunately, it didn't go so well in my earlier years because I just wasn't good enough. But what I think I might do now is be a potter, a ceramicist. So that's sort of my hobby on the side. And it's something so relaxing, so different than anything else that I do. And really, there's nothing like going out to your wheel, putting on some music and just sort of trying to get this lump of clay to go from being a lump into some shape that you preconceived. So
not that different from being a psychologist in some ways.
In some ways. And I will say that sometimes it works and sometimes it doesn't. But the more that you practice it, the easier it goes, just like most anything else we do.
So do you have pieces like ceramics that you've gifted to people?
Yeah. I'll bring one next time we hang out.
Awesome.
It's there's nothing like a handmade gift. I think.
I would love to have an Eric Storch original.
Oh, yeah. It's funny, the rejects, the ones that I make that after I'm like, oh, that stinks. I gift them to Goodwill. And in my mind,
Maybe I should hit the Goodwills up around here.
well, I mean, I say this completely joking. There's absolutely no hint of narcissism on this at all. But it's like, I'm like, well, maybe one day it'll be like a Picasso and someone,
Somebody be like,
in early,
I found it.
yeah. And then they'll be like, ugh, this is useless.
Do you sign them on the bottom?
Yeah.
Okay.
Yep. A friend gave me actually my signature, and so we just sort of printed in
A stamp.
Yeah. Yep.
Very cool.
Yeah. It's a lot of fun.
Do you have a particular glaze you love to work with?
That's actually been the biggest challenge. So in my city studio versus my private one.
Gosh, you are a full-blown artist.
I have a massive kiln. I mean, everything.
Wow.
Yep. Just don't count my insurance company that way.
Okay, sure.
But in the city one, you have glazes that you dip in, and there are a few that I really love that are sort of blue or green or so on. But in my private one, mixing your own glazes, it's sort of like being a chemist. Not sort of, it's completely like being a chemist. And you have to get it exactly right. So on that, I've been struggling to find the ones that I really love. By my last glaze fire, I did. So I'm really excited.
Fire, like not a fire, but like when you were firing the
When I was
fuse.
firing it.
Okay, got you. Yeah.
Yep. And so right now I'm pumped with this mixture of two particular glazes to give it like a really nice gray tint, actually similar to the chair you're sitting on.
Oh,
Yeah.
lovely.
Yeah.
Cool. Well, that's why we picked these chairs. I love raku. Like, I
Oh,
would
that's not
love to learn that, which you can edit this out later. I'm just riffing, but I love this stuff. We talked about this.
Yeah. Raku's crazy. It's
Yeah.
like chaos.
It is.
yeah.
I love it.
Yeah, I know.
Very cool. All right. That's treatment center versus university right there.
Mhm.
You see,
Yeah.
love the chaos. You like it organized, gray like the chair. Okay. What's one thing about yourself that clients or colleagues would be totally surprised to learn?
I think people might be surprised about the Eric outside of work. So, how I am in work is exactly how I am outside. I joke, I'm not too serious. And in academia, people are pretty serious. It's not my cup of tea. But I think it's the things that I do. So I'm really proud that I've been a competitive goalkeeper in soccer for 38 years now. I recently broke my two middle fingers, so I'm now right off splints, fresh from a day.
Do you want to show them off?
Oh yeah, very nice.
They're beautiful. Yeah.
These are breaks 15 and 16.
Oh.
And what I love is my hand surgeon. When I asked her, I broke my hands a lot. Do you think there's something wrong? Her response was, well, maybe with your technique. And that was a good moment of touche. But I think that part, and then I also think my interest in just art. So what I can create in the process of creating. Right now the focus is on pottery. But this piece that's really sort of different from this very kind of focused scientific effort at play.
Well, so this is going off script, but I have a question for you.
Yeah.
Because this is an area where I have a huge interest too. So what similarities do you see between your process as an artist and your process as a psychologist? We talked about one of them, but just in general, the whole idea of being a psychologist, being a professor, being somebody who has seminal studies versus your process as an artist. What do you notice that's similar?
There are three things that come to mind. One of them is about my personality, which is when I set in to do something, there's no sort of doing it halfway. Now, I'm okay not being the best. It's more sort of my own, like challenging myself to be as good as I can be. And so I think those are two aspects that are relevant in my career and in this interest in pottery. I think a second is the process, in the sense that it just takes time. It takes time to learn the literature. It takes time to understand what a good scientific question is, or how to present it, or conduct that study. And it's the same in pottery, that it just takes time to learn everything, and that you're always learning. I love going to our local kind of pottery shop, because everyone there has dedicated their life, whereas I'm 3 years into this. And so just talking to them, every time I go, I learn something new. And they have no idea that I'm picking their brains by just talking about glazes or different tools or so on. So I think that that evolving process is important in terms of or similar in terms of the learning piece. And I think the third is have mentors, and have mentors that challenge you and are supportive at the same time, but that help you sort of stretch yourself out, taking on new challenges, but also being okay when you fail and helping you process why you failed. So I think those are a couple similarities.
Okay. If you could go back and change one thing about your career, what would it be? Besides all those goals.
Yeah.
Soccer goals, that is.
Yeah. I don't know if I would change anything about my career. I think there are decisions that you make that at the time they're the best decision possible. And maybe they turned out right or wrong, but I don't know if you could have, how well one could have sort of steered the outcome differently. I think I've been fortunate to work for 3 incredible institutions over my career to date, and each have provided different opportunities. They've had different challenges, but what's been wonderful about each is that they've given me the freedom to actualize a vision, and so that's one of the areas that's been most beneficial to me, is that there hasn't been someone saying this is what you do or how to do it. It's here's this framework for how we work. Here's your goal. In an ethical, responsible manner, achieve that goal. And that's what's been so exciting about being at Baylor, is this possibility of building from next to nothing and a thriving OCD program that integrates research and education with excellent clinical care in an outpatient setting.
Awesome. Knowing that some people out there want their career to look like yours, what's the formula you would give them?
That's scary. I think the first step is having a vision for what you want your career to look like. There's no right or wrong. It's all about you and what where's your passion. I mean, in your case, you've had this goal of how do you have robust evidence-based treatment for OCD, anxiety, and eating disorders, integrated into a continuum of care to serve kids that aren't being served. Like, you had a clear vision, and there were steps that you took in order to actualize it. And I think that's the first thing people need, is to know where they want to be. A second is get mentors that really care about your success. I have been so fortunate to have really a host of wonderful mentors. I've also had mentors that were terrible in the sense that they taught me how not to mentor. And I don't think about them too much, but the ones that have really supported me have supported me because that was core to who they were as people. And so I think that's another really important aspect. And so with that vision and with that support, it then becomes a lot of sort of, elbow grease, and how do you actualize that? And it's not going to be something that happens overnight. But it's also, I think, often something that ends up being a little bit like a train leaving the station, starts building up momentum and building that momentum. And before you know it, it's just sort of moving. And so I think that vision and that mentorship are really 2 key things, together with, roll up your sleeves and get that vision done.
Elbow grease.
Yep.
What's more important, inhibitory learning or habituation? Can you please explain the relevance of these concepts?
What's more important? Who knows? I think they both matter quite a bit, to straddle that answer. The way I do treatment really emphasizes both. But in some ways, the nature of symptoms also matters too. Now, let's go to the first part, which is, I think, most important. I always, when I work with kids, I try to frame it as we're being a scientist, we're being a detective. You have this idea that this feared outcome is going to happen, or you won't be able to tolerate something. Okay, that's a hypothesis. Let's be a detective and test, does this work? And I think that's the core aspect to inhibitory learning, is really improving learning about the way the world works. At the same time, if I said to someone, hey, you're going to know that this thing doesn't make sense, but you might still be anxious. That stinks. And so I'm also emphasizing that they're able to tolerate this, that their anxiety does go down, which it almost always does. And so I think both of those are successful outcomes. I think there's another successful outcome too, though, which we don't talk much about, which is self-efficacy. You know, so I moved to New York. I was a small town farmer, like kid who grew up on a farm in upstate New York, south of Buffalo, and went to grad school in New York. And when I was about to move down to start my internship at University of Florida, I'm just walking down, and I had this moment of self-reflection, which was like, hey, I came to New York and I survived. Like I probably screwed up here and there. I ate way too much pizza, if that's possible. I would debate it. But I was like, wow, I came to the biggest city in our country and figured it out. And did okay in grad school, made some good friends, and I'm going to a great place to continue my training. That was a sense of self-efficacy. And so I really try to reinforce that with my kids as well. Like, hey, you're strong. You can do this. You're bigger than OCD. And so I think those mechanisms are helpful to reinforce in terms of getting the outcomes that we want.
Fantastic. In your opinion, what is the most effective supplemental therapeutic modality for generalized anxiety disorder that co-occurs with phobias or OCD?
That's a great question. And it gives us a whole nother empirical thing to go after. Mm-hmm. I think teaching different cognitive strategies, for example, like ACT, can be really helpful in that space. I also think lifestyle modifications can actually be another supplemental helpful piece. For example, sleeping well and exercising are two things that really we want to make sure we give sufficient attention to. But if we have a really nice family-based cognitive behavioral therapy paradigm as our primary piece, and we're able to kind of augment that with additional cognitive components like ACT, even additional behavioral things like lifestyle changes or teaching people to relax, at times of stress, I think those could be some helpful adjunctive components.
Awesome. Did you know Dr. Hayes is also on our advisory board?
No.
Yeah.
Okay. Yeah.
He's great. I hope you guys get to chat at our next meeting.
Never met him.
Yeah, he's wonderful. His kiddo actually is a friend of my kiddo, and that's how we met. My mom was very Southern, and she is so funny. She sat down at a middle school band concert, and she is just my biggest advocate. And so she sat next to him and said, she's like, Catherine, because she calls me Catherine. She's like, you have to meet this psychologist. He is up at UNR, and y'all just need to connect. And I'm like, hi, Dr. Hayes.
It's like, oh my gosh.
I know. So he's great, and he's so down to earth, and he's like, hey, Kat, you're so great. He's wonderful, and Stevie's his kid, and Dakota and Stevie have been friends since like second grade. So amazing. We've been to many awful middle school band concerts together. How would you recommend the treatment for disgust look different than other primary OCD obsessions and core fears?
Yeah, so this is one of the things I like to talk about when I teach, and is that we actually see sort of three main drivers of symptoms. Most of them are fear-based. We have plenty of not just right, and both of those respond great to treatment. Disgust is a little bit trickier, and so, but I also think it results in us having a little bit of a different approach in how we treat. Now, a big part of that is being able to tolerate the sensation, tolerate the stimuli, as opposed to a feared outcome happening. Mm-hmm. And so I think that's one of the main ways that we do it. Now, what's important in disgust-based work or any exposure-based work is that it's really values focused. So what are the things that you can't do, but you need to do or you want to do? That's the stuff that we're really pushing our exposures on. And so the goals are always front and center. These are life goals, life requirements, like going to school, having pizza with your friends, whatever it is. And so during those times, the stress tolerance is a big focus. But what we'll also do is give tools during that time. So it could be, you kind of put yourself in another place cognitively. It could be relaxing yourself by breathing as well. So that approach is a little bit different than when we're treating a not just right experienced kiddo or someone with more of a fear-based element.
This is something that comes up a lot for us, especially in the realm of ARFID that co-occurs with OCD. That overlap is oftentimes discussed.
Absolutely. And it can be tricky if you go at it from just that exposure, only model.
Right. That makes a lot of sense. Relatedly, what are your thoughts and opinions about inference-based CBT? And what are we seeing in randomized control trials right now, as far as that goes?
Yeah. So what I've always said is let the data speak for any treatment. And as a field, if we have multiple evidence-based treatment approaches that are on our belt, this is great for the field. Mm-hmm. Now, we also have to be connoisseurs of the literature and not just believe what anyone says, whatever that is. So for example, there's a lot of enthusiasm for transcranial magnetic stimulation, which is really exciting. But on the other hand, the effects are pretty modest, and it takes 30 sessions in order to get them. So it may not be, and probably isn't, better than seeing a cat for 30 sessions, over 6 weeks. And so again, we have to think about the full context as opposed to sort of isolated elements. Now, inference-based CBT has been really exciting to see come out, and I think that there's been a one or two groups that have published some pretty promising data. The most recent study, however, definitely placed it as less significant or less effective than exposure-based therapy. And so in the study, which originated out of the Netherlands, there were two large groups of people with OCD. It's a really well done study. One group got ERP, one group got ICBT. And these are all adults with OCD. And it really hasn't been tested with kids. And so what's tricky in a type of design called a non-inferiority trial is that there are two outcomes that you can look at. So the first outcome is sort of actually the one that you're not so interested in, which is does treatment A differ from treatment B? And that's like the traditional design. You compare two treatments and do they differ? And so in that study, they were not statistically different. But that wasn't what the study was actually designed to look at. It was designed to look at this non-inferiority, which means is inference-based CBT not inferior to ERP? And so when you do that, I know it's like it makes my head spin.
Right.
When you do that, what you're saying is that there's a certain band, a certain Y box score that if it was outside of that band, a patient would notice. So the average patient would be like, oh, I feel a little bit worse off with this treatment than this treatment. And so they defined that band, and they actually found that there was a significant difference, meaning that ERP was better consistently than ICBT in that regard. And so the delta and the Y box was 2 points across every time point.
Oh, wow.
And so the take-home finding was that ICBT was effective, ERP was effective, ICBT was not as effective as ERP. And so that's what that study showed. Now, the tricky part about a non-inferiority trial is that it's really complicated to wrap one's head around these findings. But at the end of the day, the take-home finding was that ICBT was not equivalent to ERP in terms of what their primary study goal was.
Do you remember roughly what was the N of that?
Yeah, it was something like 99 per group, so about 198 or 199. So it was a nicely done trial, methodologically rigorous, great treatments. I mean, really, really conclusive in terms of that. And what was also nice is that it was done by a group that didn't develop it, so it gives you sort of another layer of independence.
Less skin in the game.
Exactly. And again, pretty conclusive findings. Now, one thing that's really important to note is it's always really hard to find differences between two active treatments. And so here, I reiterate, both treatments worked, but there is definitely a hierarchy with ERP having a 2-point superiority relative type CBT.
Great. Why is addressing parental accommodation important in OCD treatment?
I think there are a few main reasons. One is it's a core mechanism of treatment outcome.
Mhm.
We published this paper in like 2008 or 9,
I
and
remember this paper.
yeah, it was cool.
Yeah.
And it's funny, when we published it, I was like, yeah, that's cool. I never thought that it actually would be pretty impactful.
Seminal, if you will.
I don't know about that, um, but it was neat. It showed that if you reduced accommodation, that was associated with improved outcomes. And so whenever we identify a mechanism, the whole salience of that is that it tells us that that's a lever that we want to target in order to get better outcomes. And so that's where accommodation is. I think a second reason that's relevant is acceptability. Parents come to me and they don't say, here's my kid, launder him, and then I'll pick him up in an hour. They say, how do I help my child? And my response is, come partner with me. And I'm going to teach you all the things I know so that we can get your kid as good as new.
Awesome. Perhaps people that are viewing us in this conversation may not know we use a lot of letters to talk about things. So can you say, what is the Psy box? What is the Y box? You are one of the 2 authors on the front of the test. And why is it the most effective measure of OCD severity? And then I have a follow-up question as well.
Yeah. So the Y box, the Psy box, stand for the children's or Yale-Brown Obsessive Compulsive Scale. So this was a measure that one of my mentors, Dr. Wayne Goodman, created with 2 of his close colleagues who are also authors, Steve Rasmussen and Larry Price, who are psychiatrists at Brown. And then, they were really nice and, let me tag along. Now, one of the things that's so cool about these scales is that it revolutionized the way that we assess clinical outcomes in a condition. So historically, the way it was taking place, whether it was depression or other problems, was that you basically took all the symptoms that a person could exhibit, had some sort of scaling, 0 to 4, how bad is it? And then you would sum up those items. So like a really well-known and valid and solid measure called the Hamilton Depression Scale, that's what that is. How anhedonic are you? How depressed are you? 4. Okay, we'll sum that up.
You emulated your heroes.
Yes. You know what? We learned from them. We went different.
Right.
Because what Wayne did with the Y box was said, well, we actually think OCD is different. We think that we should define severity as things like time occupied or distress or impairment or how much you fight it and how good are you at fighting it. And so it was a different way of thinking about severity that I think resulted in some improved outcomes and precision in that piece. Now, what's also cool about the OCD field is every single trial uses this scale. And so it allows us to compare across studies in a way that's actually quite unique compared to other disease states. We came out with a second edition, which, I think had some improvements. One of my favorite improvements was it actually increased the scaling to be 0 to 50 as opposed to 0 to 40. And of course, as you know, when you work with these sick kiddos, you oftentimes get these kids that are really, really struggling. And so we would end up seeing a lot of folks that were at the top of the scale and they were getting better, but their score wasn't changing because, for example, they might be ritualizing 12 hours when they come in, and now they're ritualizing 9 hours. It's a huge improvement, but they still would get the same score. So this gave us a little bit more latitude in terms of the way that we assess outcomes.
Great. So how does the Y box and the Psy box differ from the DOCS, the Dimensional Obsessive Compulsive Scale?
Mm-hmm. Now, the DOCS is another super cool scale. And so one of the ways that it differs is that the DOCS focuses on these commonly defined dimensions of OCD. So it takes a Y box type approach, but really focuses on things like contamination or, intrusive thoughts about, sexual domains, for example. And so what that does is it allows you to get a nuanced rating for how severe that particular person's symptoms are. Now, there are advantages for both, and there are instances where you would want to have a more gestalt total score for how severe someone is versus where you would really be focused on the score for a particular dimensional aspect to it. one of the, I think, caveats of the docs is you don't really want to look at the total score across all the dimensions, because if someone's high on all of them, they're going to look a lot worse than if they're high on one, even though that one may be a really massive problem. So it really gives you that dimensional severity aspect in a way that I think has an advantage over the Y-box.
Very cool. Should we be expecting a new edition of the Cybox or Y-box anytime soon?
Yeah. So, and we've really been sort of slow to fully roll it out, but we have second editions of each with some, I think, strengths of the original one. I think the biggest challenge that I've experienced on that is that the whole field has used the Y-box. So you try to get people to shift to this other one. I mean, I get it. And even if the other one has some advantages, the fact that everyone's used this is still a pretty big reason there too. So I think that's one of the areas that we've really thought a lot about, of how do we roll this out in a manner that is going to be effective, that allows benchmarking against the Y-box as well, and ensures precision of administration on top of it.
Okay. Who are your heroes, dead or alive, in the field of anxiety and OCD treatment?
In my career, I've been fortunate to have a number of people that have really just helped mentor me, shape my career, the way I see things. And frankly, there's sort of too many to name overall. I am fortunate that my current boss, so I should get a point for this one, Wayne Goodman has been an amazing mentor, teaching me about how to write grants, but also about how to be a leader. And that a lot of that is that it's not about you. It's about supporting others in their career pursuits. Another mentor, a gentleman named Gary Gefkin, was someone who was really amazingly supportive at early stage of my career and helping me paint the canvas. And what I think was really interesting about Gary was that he sort of saw me for who I was, and then just almost like parted the seas so I could do the things that I really like to do. And then, last person I'd like to mention who passed away somewhat recently was Mike Janicki. And while, Mike was a mentor in a smaller way for me, being always 1,000 miles plus away, but he gave me a chance, and he invited me into this international OCD foundation community, and welcomed me in a way and supported me in these small ways by making introductions or just saying a kind word of encouragement. And so those are things that are so impactful. It's always amazing. There's a saying that I find to be amazing and inspirational, which is, to the world, you may be a person, but to one person, you may be the world. And the words that you say to someone may have a massive impact, whether it's positive or negative. And so I try to use those moments, whether they're big or small, in order to impact the people to whom I work.
Wow. What do you think about the backlash behaviorism has gotten recently? Some folks are even calling it dehumanizing.
I think there's a little bit of a straw man argument embedded within that. In aspects, I'm speaking mostly with OCD and anxiety in the context of a behavioral exposure-based treatment. It really is sort of missing the point of how this treatment's done. And so when I say straw man argument, it's really propping up an exposure-based framework as sort of bad and its worst form possible. That's not the way it's done. That's what I mean about straw man argument. So the way that skilled practitioners provide exposure-based therapy is where they focus on the individual's goals and things that they can't do or need to do or want to do. So for example, a kid, might want to just take a regular shower, but they can't because they're so afraid of germs. So they end up spending, 2 hours in the shower scrubbing vigorously. Well, you know what? What we're trying to do is target how do they get back to a life that has regular showers that are consistent with how long they want to take, or doing things that would enable them to go out and play soccer or hang out with their friends. When you frame it that way, which is exactly the way it is, it completely cuts the sort of rope off that straw man and gives no ammunition to that position. The second is that it's an incredibly acceptable intervention But we have to be mindful that anxiety and OCD are really debilitating conditions. Now, if someone had cancer and the treatment was a chemotherapy or radiation or surgery, we actually wouldn't blink an eye on that. That this is an invasive, difficult treatment that will have side effects. Instead, what we're saying is that we're going to teach you to take a different approach to your anxiety or OCD, which is not one where you back away, but one where you push forward. And you push forward in a way to achieve your goals and your values and your dreams. Boy, that doesn't sound like such a barbaric treatment approach in any capacity to me. And evidence of that, when we have skilled practitioners do it, we see attrition to be extremely low. We see acceptability to be extremely high, and we see outcomes to be incredibly robust. And so one of my personal pet peeves is when when individuals in fields do exactly that. They create straw men based on really things that aren't facts or misportrayal of facts. I don't have any belief that I will always be right or that I will win every argument or contest or every study or that I'll get every grant. But what I do believe is that we need to make sure that we're playing with really a stack of cards that's full of integrity in terms of making the best decisions that help our patients.
Thank you so much, Dr. Storch, for being here today and answering all these questions for us.
No, it's a complete pleasure chatting, and I know it won't be the last time.
No. I do need everyone to know that's watching this right now that it is currently like 9:30 in the morning. Very early for mackerel and tomato sauce. Hi there, I'm Kat Geiger, founder and CEO of Thrive Wellness Reno, and I am here with the world famous Dr. Eric Storch from our advisory committee, most importantly, but also Baylor College of Medicine. He's an endowed scholar, yada, 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 all the important things. And we're asking him to do something very scary today. We are asking him to play a game with us called Spill Your Guts or Fill Your Guts. Many thanks to James Corden for coming up with this game initially. We in the OCD treatment world and anxiety treatment world, and especially the ARFID treatment world, love this game because it really takes this cool psychological concept of values-based exposure work and puts it into practice. So I'm going to be asking Dr. Storch questions that may ask him to challenge some of his values, like values of loyalty, values of being socially acceptable, those kinds of things, and choose to engage with disgust, with something that may be disgusting to him. So we have foods that are very unfamiliar to us. These may be delicious to you. I don't know. But for us, they're very unfamiliar. So tomato sauce mackerel and tomato sauce. I believe the skin is still on. We've got sardines that are in salt water, and we have preserved black duck egg. I'm just going to hold this up so the camera can see how delicious that looks. We've got octopus flavored taco chips. We've got a loaf of chicken and beef that you can see is nice and congealed in here. We've also got hot okra pickles. So I could not be more excited to ask you to do this with me today. How are you feeling?
Well, it looks delicious. I didn't have breakfast, so I'm raring to go.
All right. Well, buckle up, Buttercup. Here we go. Who is the least favorite person you've ever collaborated with on a paper? So this doesn't mean you don't like them. It just means you like them the least out of all of the people you've ever collaborated with.
Oh, boy. I'm going to have to keep that one secret. All right. So sign it up.
Oh, no. Okay. Well, I'm going to be really kind to you and let you choose out of the many, many things instead of choosing for you.
Well, I'm thinking about, let's start with some chips.
Okay.
Okay.
So the octopus flavored chips.
Delicious.
Let's see. How do they smell? Like, let us know how they smell.
They smell a little bit like octopus.
Do they? How does an octopus smell to you?
A little fishy.
Like briny?
But if you maybe put 2 in, it's like better.
Okay. Oh, good. You'll really get the flavor. Yeah.
It's not bad.
Is it not really? Like you'd eat these with lunch today, maybe.
Yeah.
Yeah.
Yeah. I have a secret. I like to put out weird foods in our break room and just see how people react to them.
Love that.
I might not put those out.
You might take them for yourself.
It's possible.
Wow. All right. Peanut butter and jelly sandwich and octopus chips. Who wouldn't love that?
Yeah, exactly.
Okay. What would your colleagues say is the most cringy habit you have at work?
Cringy habit at work? Well, I think there could be 2 that come up. So one is I've been battling nail biting my whole life. And I know exactly how to treat it. I can put this crappy tasting stuff on my nails and then I'm just like, oh, I won't bite it. I bet that would be number 1. The other one is more recent. I shared with you, I just broke 2 of my fingers. And so I would take off my splints because it was keeping me from typing. And like my fingers were sort of deformed. And one person made a comment in a meeting like, what's wrong with your hands? It's freaking me out. And so that one might be the other one.
Okay.
Yeah.
Taking off your splints. Got it. Okay. What research is coming out right now and who is doing it that you trust the least?
I think I'm going to have to eat on this, but I think there's a point because I don't feel like I'm answering directly, but it is a point to make. Like, I think with AI broadly as a field, there's a lot more research that's sort of coming out that's not good, but it's much harder to detect sort of the flaws or some of the issues. In college professors or high school teachers, they're seeing this with reports not being written by the student. So I think stuff like that broadly is coming out, but I don't think it answered the questions.
No,
I do need to.
You didn't answer. Yeah. You definitely avoided the question.
Yeah.
Which avoidance is so strong in these kinds of scenarios, exposure scenarios.
Yeah, this is true.
Yeah.
This is true. Okay.
It's apropos. Okay, I'm picking this time.
Oh, boy.
I think it's time to try some mackerel in tomato sauce.
Yeah.
You're welcome to do that with a cracker.
Yeah. How? So I'm totally curious. It sounds good. Is it?
Does it?
Oh, so that's where it is. I was trying to figure out how it kind of works.
I do need everyone to know that's watching this right now that it is currently like 9:30 in the morning or 9:15 in the morning, maybe somewhere in there. Very early for mackerel and tomato sauce. Here, I'll hold it for you.
Thank you. I guess I gotta stab it. Okay.
Is that an eye?
Might be. It might be the forehead. Yeah, this looks good.
It's less good. Is this one going to make it to the break room?
Oh, yeah.
You're not saving this one.
100% gonna make it.
Okay.
With like toothpicks in there. Just to make it easy for people to pick out of.
That's perfect.
Yeah.
Oh, you're so brave. Okay. What graduate program out there that focuses on anxiety and OCD would you recommend as the last choice for someone looking to specialize?
Yeah. All right.
That egg is looking real lonely.
Oh.
Oh, look how lonely it is. Oh,
Uh, gross.
oh no. It's brined, so there's going to be a salty flavor. You know what? If you couldn't see the color, I wonder if it would taste as what it's going to taste like. I wonder if it would look as scary.
Similar shape as my head, I guess, but okay.
Oh, it's black all the way through. Are you okay?
Mm-hmm.
Oh, your eyes are watering.
It's the tears of happiness.
From the delicious
Oh, do I
duck
have to
egg.
keep eating this?
No, one bite is plenty. Thoughts?
I won't put it here for later.
Okay, yeah, for your colleagues.
Ugh.
We have a dozen of those.
Yes. That's going to be the best.
Okay, let's see. What is your biggest therapy session or research failure? The one that you still replay in your mind?
A therapy session failure, without going into too many details, would be where I misjudged a kid's ability to handle an exposure, but I didn't get their buy-in before I did it. So I thought they could do it. I was going with my gut. My gut was wrong in that moment. But more importantly, I didn't say, hey, how about we try this? And here's what we would learn from this. Here's why it would make sense. And so it didn't go well. And that was a mistake on me that I fortunately learned a lot from early in my career. On the research side, I think everything's an opportunity to learn. And even non-significant findings are significant in a way. I referenced in our last video a study where we compared 2 treatment arms and found absolutely no difference between the 2 of them in children with OCD who received D-cycloserine or didn't. And one of the things that one of my mentors said to me when I came in, sort of dejected because, I mean, mind you, this was 10 years of work to that point in time where we analyzed everything. And he said, Eric, he said, look, I challenge you with 2 things. One is pick out the sort of the gold from that. The other is, you know what? You can't win them all. And in the field will actually believe in your integrity when you disseminate non-significant findings. And so it was a great reframe on that every result is a result. It just might not be what you hypothesized, but that's what being a scientist is about, is you don't always get what you want, but you try real hard. And
you might get what you need.
Yeah, exactly.
Yeah.
Those would be a few thoughts.
What's a therapy approach that's popular right now, but you think might age like milk?
I'm going to take a bite on that.
Take a bite of this?
Yeah, that stuff. But I think there's something important that needs to happen in the field, which is that we need to reduce variation in care. If you went to your nephrologist or your cardiologist or whoever, and Dr. 1 gave you a dramatically different treatment plan than Dr. 2, who is different than Dr. 3 and Dr. 4, when only one of those or 2 of those treatment plans have been validated, you would then quickly consult with a lawyer and, if you're still alive, be pretty rich. That's one of the things that's very difficult in our field right now, is that there are a lot of interventions that don't work, but that are being done, and we need to reduce that variation significantly. And so I think in some instances, and we published on this, there are some treatments that are being inappropriately done for certain conditions. So for example, maybe I don't have to bite. This is sort of whereas EMDR has shown efficacy for trauma, has shown absolutely no efficacy for things like OCD or anxiety, and thus should not be used for that. Now, that could be taken as a challenge to a proponent of that intervention to do a rigorous study to establish the efficacy of that intervention. But in the absence of that, there's absolutely no basis for extending that treatment to a disease state like OCD or anxiety.
Right. So can I ask a clarifying question? You're not saying that it shouldn't be used for maybe trauma that co-occurs with OCD. So if you've treated the OCD, done ERP around all of those kinds of things, and then this person has a secondary trauma because they happen to be in a school shooting or something like that, would you advocate for
Yeah, I think it could be one of several validated trauma treatments for the trauma as your primary target or outcome.
Right.
And other very effective treatments, which are things that I would do, are things like TFCBP.
Yeah, or
prolonged
prolonged.
exposure.
Yeah, right. That's what I use. Yeah, that's great.
Okay.
That counts. You don't have to
Beautiful.
say goodbye.
Okay.
Is there any researcher in the field that you were like, I will never read their studies again?
No. I mean, there's of course researchers, clinicians, people, you know, in the field or your social network or whoever that you don't want to grab a coffee with.
Yeah.
But I think the minute you close yourself off to others' perspectives is where you stop understanding how someone else is seeing the world. And and I think it's helpful to try to understand that. Sometimes it's really hard to understand the perspective or position or rationale. Um, but no, I try to remain open. I think finding the time is a different
Sure.
piece to it.
What's some advice that you give to your clients, but maybe you don't take yourself?
I mean, this is sort of weak, so I'll own up on taking a bite of something. I don't exercise as much as I want. With 3 kids and I travel a lot for work. Finding time is hard, and when I have time available, I tend to either hang with my kids and do something. Yeah, when I'm not her, play soccer, or mostly it's pottery. Outside the kid thing. So like the gym just falls sort of off the priority piece, and outside of soccer, I guess. But I'm a goalie, so you really don't exercise that much there. But I will say I really think about this notion of facing your fears and then learning from the process of doing that. And even when it's difficult, I still push myself to do it. And
I mean, here we are.
yeah. It's look, like part of the perspective on any of that stuff. I mean, all this stuff is gross. That I thought was gross, but actually was pretty good. Crackers are good too, for the record. But like, right, like what's going to happen? It'll be over. It won't always feel this way, and I will learn something about myself. And so I'm fortunate. Like I have, I'm not a particularly anxious guy. I'm not compulsive in a problematic way. And but I always think with the people with whom I work, their conditions are keeping them from doing the things they want to do in life. And so sometimes that means we got to do stuff that's difficult in order to get there, and in order to achieve those outcomes. And so, here, if me eating some nasty foods and people laughing at the faces I make, helps one kid get to a slightly better place and say, if he can do it, then I can do it. Then that's the goal. Like, you save the world with that mentality.
Awesome.
So anyway.
Well, thank you. I appreciate you engaging in this nasty, disgusting food exposure. And I think that's a wrap for us.
All right.
Thank you again, Dr. Storch.
Of course. Okay.